maybe the most important here is my Twitter and my email if you want to get in contact with me. I put it here, the journals that I work for, the most of them, and the hospitals where I had appointments or have appointments. Okay? Well, this was, do I need less light here? You would prefer a little bit less of lights here? What do you think, Ricardo? It's okay, okay. This was published in 200, you see here, 2001, about what is the diagnosis of diabetes. Okay, these are the basic diagnostic criteria for diabetes based on glucose and HbA1c, which are the most used surrogates for diabetes. Well, that is the point here. It's only a diagnostic marker. We shall not use glucose or HbA1c for prognosis or for treatment. This is only for diagnosis, and that is it, okay? So, let's go ahead. So, the most advancements is because we are aging. I was talking with a guy from Osaka. He said he thinks everybody should live until 100 years. I don't think I think the same way as he does. But the biggest advancement is in the people with diabetes who is becoming older. People more than with at least 65 years is the most growing population with diabetes in the rest of the world. Not only in China, but everywhere. Not only in Osaka, but everywhere. This is a paper that I published a little less than 1 year ago, saying that we need to be more flexible with older people. We don't need to go by the book with older people. They are different than younger people. Yeah, and maybe this is why I have a relationship with Omics, because it took me 9 months to be published, because I didn't want to pay $150 per page. So as I didn't want to pay that, it took me 9 months to be published. Okay? These are some tables from the paper who says some interesting things. It says here, the epidemiology of type 1 is not changing. That's not really true. Type 1 is also increasing everywhere in the world. Not only type 2 is increasing. Type 1 is also increasing. And nobody knows why. Maybe because of the junky food, maybe because of our junky lifestyle. But type 1 is also increasing. This is not quite correct. We have a whole bunch of microvascular disease. This is also not that quite true. You see, this was a paper that I published together with 2 other authors. They have this more conservative view. Type 1 is also dying mostly of cardiovascular disease, macrovascular disease, okay? And microvascular disease is not that much frequent as usually said in the literature. You see microalbuminuria, this is true. This is more specific in type 1. In type 2, it's not specific at all. In type 1, microalbuminuria says that this patient has not only endothelial disease, but has a more tendency to get renal disease, which is not, okay? Nobody knows why it happens in 30 to 40% of type 1 diabetics. Not more than that, but not less than that in every series in the world. So proteinuria, so it has some specificity in type 1 microalbuminuria, but not in type 2. Doesn't mean anything in type 2. Proteinuria is usually heavy in advanced type 1 diabetic nephropathy, and it's mostly type 2 diabetics. They are usually elderly people. They have very low albuminuria, even absent albuminuria, and they get very slowly into end-stage renal disease. Ricardo, are you here? Okay. Philip, take care of my time, please. Okay? They have a faster progression to end-stage renal disease here, a much slower, really very much slower. People say we have an epidemic of type 2 diabetic nephropathy. I don't think we have that. They need tight control here. Not that much tight control also, type 1, not much that tight control. But in type 2, we really don't need a tight control. Let's go. Let's move ahead. These are very much a quite common problem. Drugs that we should not use in diabetics. Okay, we need to avoid these drugs. You see, renin-angiotensin blockers is another myth, another dogma. Anti-inflammatories. Okay. For older people with diabetics, healthy lifestyle is the best measure. Individualized approach, stay away from guidelines. Be holistic. Share your decisions with patients and health caregivers. And every now and then check the medications to avoid polypharmacy, which is another very bad thing for type 2. This is a recent work, more than 100,000 people. You see how bad is our literature, correlating HbA1c level with all-cause mortality. Let's go. You see for male and female. So people take those association of epidemiology studies to make extrapolations to treatment. This is a wrong mistake. You cannot extrapolate from epidemiology study to treatment. They are only association studies. This is very common. And some strong professional associations take those things by the book. So recently, you see this, the European Society of Cardiology meeting, they laughed about the Endocrinology Society because of a recent New England Journal of Medicine paper. Was a negative paper who was very applauded when it was presented. So the cardiologist says, how can people be so happy with a negative paper? We don't understand that. Maybe Dr. Houck could give some explanation at his talk, okay? So this was published about 2 weeks ago at the British Medical Journal. This is the main guy from the media who talks about on TV, on journals, on television. I think this is the most important diabetologist alive. He works in London. So there is no great link between glucose and diabetic complication. There is not at all. This is another fallacy. I don't know if I'm speaking English or Portuguese or Italian. I hope I'm speaking English here now. And there are very much new anti-diabetic drugs. They are not safe. They are not effective, okay? Since rosiglitazone, no one of them. So this is my final slide. Do not trust guidelines, especially if they come from specialty associations. I can give a few numbers. American Diabetes Association, European Study for Diabetes, and so on. And do not give to microalbuminuria and HbA1c and fasting blood glucose the status of a disease. They are just surrogates, and very poor surrogates for diabetic complications. Okay, I hope I'm speaking English and not Italian and not Portuguese. Okay? Do not trust newer anti-diabetic drugs, even insulin analogs. They are toxic, they are not effective, they are not safe. And always individualize your decisions. Do not give too much credit for those, and share your decisions with patients. There are other messages. Do not go for treatment because of epidemiology studies and so on. So that's it. Thank you very much.